short video today.
A 28-year-old woman comes to the office for follow-up of an 8-month history of anxiety nightmares and flashbacks after returning from A 28-year-old woman comes to the office for follow-up of an 8-month history of anxiety nightmares and flashbacks after returning from a military deployment. She has been taking sertraline for the past 6 months. 6 months and completed a course of cognitive behavioral therapy recently. The patient reports her symptoms have mostly improved, and she no longer has intrusive thoughts or flashbacks related to her time in a combat zone. She says, "My mood feels lighter, and I've started spending more time with friends and family. I can't seem to sleep through the night though. I'm still having scary dreams about my time in the army." She drinks a glass of wine twice a week and does not use tobacco or illicit drugs. Medical history is non-contributory. Vital signs are within normal limits. Physical examination shows no abnormalities. Which of the following is the best next step in management of this patient?
Seems like she's already on CBT, so Prazosin. Otherwise, I would choose CBT. Clonazepam. Let's not get ripping so yet.
A 64-year-old man comes to the emergency department due to palpitations and progressive shortness of breath over the past several weeks. The patient says that he develops a choking sensation accompanied by a dry cough every time he lies down. He has had no chest pain, sputum production, lightheadedness, or syncope. His other medical conditions include hypertension for the past 20 years and medication non-adherence. He also has a 35-pack-year smoking history. The patient's father died of a heart attack at age 70, and his mother suffered from asthma. Blood pressure is 182/105 mmHg, and pulse is 120/min, and irregular. Lung examination reveals bibasor crackles. There is 2+ pitting edema of the lower extremities. Bedside echocardiography shows a normal-sized left ventricle with wall hypertrophy, left ventricular ejection fraction of 55%, and no significant mitral or aortic valve disease. Which of the following is most likely responsible for this patient's symptoms?
With preserved. I did not know this. Right. To have heart failure with reduced ejection fraction, it would be below 40%. So there's this 40 to 50%, like maybe not. I find that funny. I did think this person had like heart failure in my head, but the thing is, he has like wall hypertrophy. I guess you can have heart failure with hypertrophy. I was thinking more of like a constrictive cardiomyopathy. Let's see. Interesting.
Heart failure with preserved ejection fraction results from impaired diastolic relaxation, i.e. diastolic dysfunction in the setting of a normal left ventricular LV ejection fraction, i.e. 50%. Concentric LV hypertrophy due to chronic hypertension is usually the primary contributor. Patients develop typical heart failure symptoms, dyspnea, orthopnea, lower extremity edema resulting from elevated LV diastolic filling pressure, and reduced cardiac output.
Really having an allergy day, and it's really annoying because like I haven't even gone out today, and I already took my allergy medication, which is like fuck.
A 54-year-old man comes to the emergency department due to shortness of breath. Over the past 2 weeks, he has had progressively labored breathing that now occurs even at rest. He has had no chest pain, cough, fevers, night sweats, nausea, vomiting, or weight changes. The patient does note frequent attacks of epigastric pain for the past 10 years, which occur twice a month and last a few days at a time. Medical history is significant for alcohol withdrawal seizures. The patient has consumed 7 or 8 beers a day for the past 20 years. Temperature is 37.7 C. 98.8 F. Heart rate is 95/min, and respirations are 23/min. Oxygen saturation is 92% on 4L oxygen by nasal cannula. Physical examination shows decreased breath sounds on the left side along with dullness to percussion. The abdomen is tender to palpation in the epigastrium without rebound or guarding. Extremities are warm and well perfused without edema or clubbing. Chest X-ray reveals a large left-sided pleural effusion. Thoracentesis results in removal of 1.5 L of fluid. A sample is sent for analysis, revealing the following.
Amylase. Not heart rate, or not this one, because I don't know, it just doesn't seem like cardiac, but he for sure has like this is due to like, you know, like that. Pancreatic fistula? Wow. Like, I know it was a transitive. It should be a transitive. Is it a transitive? It's an exudative? Oh, I've never heard of a pancreatic pleural fistula. Interesting. Because usually when the protein's like lower than the regular serum protein, that usually suggests transitive. Usually.
A pancreaticopleural fistula between the pancreatic duct and the pleural space, resulting in an amylase-rich exudative. Pleural effusion occurs most commonly as a result of acute or chronic pancreatitis. Management includes bowel rest to promote fistula closure. Endoscopic retrograde cholangiopancreatography may be required. A 35-year-old man with aplastic anemia undergoes bone marrow transplantation. The donor is an HLA-matched sibling. 2 weeks after the procedure, he develops a maculopapular pruritic rash that is predominantly found on his face, hands, and feet. He also complains of diarrhea. The stool is positive for occult blood. Liver function tests are abnormal. Which of the following is the most likely pathophysiologic mechanism of this patient's condition?
I can only think of one transplant rejection or whatever transplant issue, and that would be like activation of no, what is this?
The clinical scenario described is typical for acute graft-versus-host disease, GVHD, which is common after bone marrow transplantation. Up to 50% of patients with bone marrow transplantation from matched siblings develop the disease. The target organs for GVHD are the skin, maculopapular rash involving palms, soles, and face that may generalize as typical intestine, blood-positive diarrhea, and liver abnormal liver function tests, and jaundice. The basic pathophysiologic mechanism involved is recognition of host major and minor HLA antigens by donor T cells and consequent cell-mediated immune response. GVHD is caused by recognition of host major and minor HLA antigens by donor T cells and consequent cell-mediated immune response. The organs that are typically affected include the skin, intestine, and liver.
Okie dokie. Let's see what C was.
Activation of the host T lymphocytes mediates the rejection of the graft, thereby resulting in the depression of myelopoiesis. Failure to generate blood cells manifests a severe neutropenia for several consecutive days and increased risk of infection. Graft rejection may occur in up to 20% of high-risk patients.
Interesting. So basically by saying activation of host T lymphocytes is saying that it's graft rejection. It's not graft rejection, it's just probably some sort of, it's just graft acute. Yeah, that's what it was going for. Fuck my allergies, bro. Why?
A 74-year-old woman comes to the emergency department due to sudden onset of complete vision loss in her right eye. Her vision had been blurry for the past 24 hours and acutely worsened an hour ago. The patient has had no weakness or sensory changes in the extremities. Review of systems is positive for 2 months of generalized headaches. She has no nausea or vomiting, but does have malaise and fatigue. Medical history is significant for type 2 diabetes mellitus, hypertension, hypercholesterolemia, and bilateral cataract surgeries. Temperature is 37.2 C, 99 F. Blood pressure is 156/86 mmHg, and pulse is 78/min. Examination shows complete loss of vision in the right eye. The pupils are 4 millimeters bilaterally. Fundoscopy shows a swollen pale disc with blurred margins. The lateral scalp is tender to palpation. Cardiopulmonary examination is normal. Motor and sensory examinations are normal. Which of the following is the most appropriate therapy for this patient?
Okay, so I'm between temporal arteritis and like acute open angle glaucoma, just because they kind of that blurred margins, but the lateral scalp is tender. But like, what would that matter? Generalized headaches? I mean, if it is, it would be high dose. She could also be having a stroke, like a central retinal artery occlusion. But something says, oh, well, yeah, her age does kind of suggest this, and maybe like a stroke. I mean, I guess it all is. Let's just, I don't know what that is. Like, I know that that's temporal arteritis, or an allusion to, but I don't know that they ever said that your lateral scalp would hurt. Okay, so it is giant cell arteritis, temporal arteritis. Fun fact, in this case, I would try to get in like a stat ESR, just to see if it's above 50. If it's above 50, then
giant cell arteritis,
I know what to
GCA,
do.
or temporal arteritis, presents with headache and systemic symptoms: fatigue, fever in patients age 50. Potential complications include anterior ischemic optic neuropathy, which can lead to blindness. Threatened vision change, or confirmed vision loss in GCA requires high-dose intravenous glucocorticoids.
Okay, so stroke doesn't present with blindness. So it's closure, glaucoma, ocular pain, nausea, and vomiting. I guess corneal opacity makes sense. That's the only thing. A fixed mid-dilated pupil. Interesting.
Urinalysis shows 1 plus glucose and 2 plus protein, and is otherwise unremarkable. Biopsy of the transplanted kidney reveals heavy lymphocyte infiltration with vascular involvement and swelling of the intima. Which of the following is the most likely cause of this patient's renal dysfunction? 52-year-old man comes to the clinic for follow-up. The patient has a history of diabetes mellitus type 2 and end-stage renal disease due to diabetic nephropathy. He underwent living donor kidney transplantation 5 months ago. The patient's immunosuppression regimen includes prednisone, tacrolimus, and mycophenolate sodium, and he also takes insulin. At his last clinic visit 3 months ago, he had good renal graft function with serum creatinine of 1.2 and trace proteinuria. In the interim, the patient has had no symptoms other than mild fatigue. Temperature is 37.3 C, 99.1 F. Blood pressure is 146/82. MMHE pulse is 78/min and respirations are 12/min. Physical examination is unremarkable. Laboratory studies are as follows.
Five months ago. Interesting. Doubt it. Guess it does. Was he at 5 months, was it? Dang, they really pushing it on that one.
This patient is most likely experiencing acute renal allograft rejection, which is predominantly a T-cell mediated response to antigens within the donor kidney. The use of immunosuppression with calcineurin inhibitors, EG, tacrolimus, and antiproliferative agents, EG, mycophenolate markedly reduces the incidence of acute rejection. However, it is still a risk. When it occurs, it is most commonly within the first 6 months following transplant. Patients with acute rejection are usually asymptomatic, but they may have fever, decreased urine output, or graft tenderness. The process is usually recognized by acutely increased serum creatinine, often accompanied by proteinuria. Diagnostic confirmation requires renal biopsy, which characteristically reveals lymphocytic infiltration of the intima with inflammatory tubular disruption. Intimal arteritis is often